Shilpa, can you mute everyone?
Yes, I'm going to mute all.
Yeah, set the host and
Kripakaran sir, unmute.
yeah.
Dr. Angu sir. Dr. Angu Kumar.
Hello, yes.
Keep your headphone also ready, sir. If there is
I'm
a problem, you can use that.
Abdiya, do you want me to, okay.
Shall we?
Yeah. Yes, we are live on YouTube.
Yeah. There are totally 136 participants right now in the forum.
You should start, Kripa. We are on time. You
Right.
start the initial announcements and then we'll get on with the meeting. Thank you.
Shall we start?
YouTube live is on. Is everyone, any speakers, anybody who wants to speak, you can unmute yourself because unless you unmute yourself while you are speaking, your voice will not be heard. So you can start, Kripa. Thank you.
Right. Shall we?
Yeah.
Yeah.
Okay.
Okay. We are starting our ISA Tamil Nadu webinar program, CME program number 3 on this Sunday. It's a special day for all of us because we have two special guests from abroad, United Kingdom, Dr. Srinivasan Sambath Kumar and Dr. Anku Kumar. We welcome both of them for the CME program. And we have our moderator from Andhra, Dr. Kameshwar Rao. He is a well-known person among the anesthesiologists, ISA throughout the country. We welcome you, sir. We are really honored to have you, sir.
Thank you, sir. Thank you.
And few instructions for the delegates. Please type your own name, original name, and log in. Second, please enter your name, mobile number, and email ID in the chat box. Then only we can verify your presence. Okay. So with that, I welcome Dr. Kannan Bojraj, of President of ISA Theni branch, to give welcome address. Dr. Kannan, please. Yeah.
Unmute, sir.
Okay. A very good morning to all. Indian Society of Anesthesiologists, Theni ISA is hosting this program by the help of ISA.
Keep your mic close.
Hello.
Mic
audible,
close.
sir?
Yeah, mic close.
Mic close, sir.
Yeah, now it's better.
And this is a special webinar of third webinar of Tamil Nadu ISA because the chief guests are all from overseas, outside India. And I welcome our ISA State President, Dr. Sudarshan Kasturi. He is a consultant anesthesiologist and of GEM Hospital, Coimbatore. He's a dynamic president who is more interested in academic activities and maintaining this webinar for this COVID-19 pandemic. We are updating our knowledge by this webinar every week. It is a very interesting area. I welcome our other chairperson is Dr. K.S. Kameshwar Rao, past president, ISA National, Dean Kims Amia from Andhra Pradesh. Is going to chair the session also. Both of them going to chair the session, sir. My heartful welcome to both these chairpersons. And I welcome our ISA State Secretary, Dr. Kibaran sir, soft-spoken and dynamic personality, is going to give the welcome address at the end of the session. And I welcome Dr. Balasubramani is going to give our branch report at the end of the session of special speakers. And I welcome our academic coordinator, Dr. Edward Johnson, who is more interested in academic activities and much more interested in teaching the postgraduates. He is the professor and head of Department of Anesthesiology, Kanyakumari Medical College. I welcome you, sir. And I welcome the top speakers, special speakers. Dr. Srinivas Sambat Kumar is the consultant anesthesiologist in Basildon and Thurrock Medical University Hospital, Essex, United Kingdom. He's going to talk about anesthetic consideration in laparoscopic surgery. And another speaker, Dr. Rangakumar Thangamuthu, is going to talk about the oxygen therapy in COVID-19 patient from the same institute, UK. Both of them, my heartiest welcome to you, sir, for this nice occasion. And I welcome all the members who are the participants from all over India and all over the world who are interested in participating in this webinar for this nice occasion. Thank you.
Thank you, Dr. Kannan. We recognize the presence of our Tamil Nadu ISA past president, Dr. Subaya from Madurai, and our president-elect, national president-elect, Dr. Venkatagiri, and Dr. Gurudat from Mysore. Now we will move on to felicitation address by our state president, Dr. Sudarshan. Dr. Sudarshan, please.
Good morning, everyone. Respected President-elect Dr. Venkatagiri, immediate past president and chairperson for the day, Dr. A.S. Kameshwar Rao, all the senior ISA state and national office bearer members who attended today's meeting, all the president and secretaries of every ISA city branch all over the state, my dear members, friends, and dear colleagues. It's a great pleasure to be associated with this webinar series. Every week, conducting one webinar series, and this time it's, as everyone mentioned, it's a special meeting, and we have two speakers who spared their time on a Sunday morning, because it's very early morning, as I said earlier. It's about 5:30, 6 o'clock for them, to spare the Sunday morning to give us a talk on very important and interesting topics for the day. And I'm sure already we have crossed about 225 viewers on the live webinar. I think its number is going to increase as the time goes. And without wasting much of time, let's get on with the educative program, and then enjoy yourself, and it'll be a useful day for you all, and a happy learning. Thank you.
Thank you, Dr. Sudarshan. Now we will move on to academic session. Before that, I recognize the presence of Dr. Srinivasa Surisetti, Secretary of Andhra Pradesh State. Welcome you, sir. Now I'll hand over the session to Dr. Edward Johnson. He is our academic coordinator for Tamil Nadu ISA. Dr. Edward Johnson, please take over.
Thank you, Thiruvaran. So I welcome you all for the third CME of the Tamil Nadu ISA. So today's topics are the anesthesia consideration for laparoscopic surgeries by Dr. Srinivasan Sambat Kumar. And the second topic is oxygen therapy in COVID-19 patients by Angu Kumar and Thangamuthu. Both are for overseas speakers. We are grateful and thankful to them for sparing their valuable time, that too in the early morning. Thank you, sir. And Dr. Sudarshan will introduce the speakers. And today we have two chairpersons, the Kameshwar Rao and Dr. Sudarshan. Both need no introductions. Dr. Kameshwar Rao is the Dean of Konaseema Institute of Medical Sciences, Andhra Pradesh. And he is the past ISA National President and past ISSP National President. And he is interested in pain and palliative care. We welcome you, sir. We are being honored to have you among the chairpersons, sir.
Thank you, sir.
And the second chairperson, you need reckon no introduction. He is the Dr. Sudarshan is the sitting president of Tamil Nadu ISA, and he is the HOD and senior consultant of Gem Hospital, Coimbatore. And he is the stalwart of ISA from Tamil Nadu, well known and very popular. We welcome you, sir. And over to Dr. Sudarshan. to introduce the speakers.
Unmute yourself.
I need to, before we start introducing the speakers, a few words about our co-chairperson, senior person, Professor Kameswar Rao ji. I have a lot of fond association with him in Andhra Pradesh. We used to attend many of the CMEs arranged by him in his hometown. It is something of a different experience. I think I would recommend everyone to go to Amlapuram. Experience is hospitality. Only if you visit there, you will understand what I am trying to say. And they are extremely nice and academically very motivated. And KIMS Institute is flourishing because of Dr. Kameswar Rao's association over the past several years. And I'm sure I'm very happy to have you. And one request from myself to Dr. Kameswar Rao to be the chairperson today. Without hesitation, he agreed. And thank you very much, sir, for your acceptance and participation today. May I request Dr. Kameswar Rao to introduce the first speaker, Dr. Srinivasan Sampath Kumar. We'll get on with the talk by Dr. Srinivasan Sampath Kumar after that. And then the second speaker I would introduce, and then he can have the talk after that. So let me request Dr. Kameswar Rao to share his felicitation address and then introduce the speaker. Thank you.
Thank you very much, Dr. Sudarshan, for your kind words. First of all, my sincere thanks to you as President ISA Tamil Nadu for giving me the opportunity to chair today's scientific sessions along with you. That is the greatest opportunity for me. And I appreciate the city branch of Theni ISA for conducting this webinar with one great hour also from Tamil Nadu Medical Council. And a member from Medical Council, Dr. Shanmugam, also is present here. I'm very happy for that, and I welcome him. And I congratulate Dr. Kannan, the President, and Dr. Balasubramaniam, the Secretary, and also State President, State Secretary, Dr. Krupakaram, and the Academic Coordinator, Edward Johnson. I invite both the international speakers, Dr. Srinivasan Sampath Kumar and also Dr. Angu Kumar. And the topics selected also are excellent and most useful for all the postgraduates as well as for the practicing anesthesiologists. And very important topics are selected by the international and the international speakers also are selected for this. And they made their time convenient to address such a big gathering today and very useful topics. And I am extremely thankful to both the speakers. And I welcome all the delegates and participants for this webinar. Thank you very much. Before that, and I'll introduce a few words about Dr. Srinivasan Sampath Kumar. He is today dealing with anesthetic consultations for laparoscopic surgery. And he studied medicine and anesthesia in India and moved to UK in 1994 and completed his training there. He obtained a CCST in anesthesia and became a consultant anesthesiologist at Basildon and Turak University Hospital, NHS Trust in 2001. Presently, he is a senior consultant in anesthesia and he will be delivering lecture on anesthetic consultation for lap surgery. Over to Dr. Srinivasan Sampath. Thank you.
1 minute.
Before that, a few words from
Before that, we recognize the presence of our past ISA Tamil Nadu President Dr. Selvakumar here. And also we recognize the presence of our Tamil Nadu Medical Council observer, Dr. Shanmugam. He is also an anesthetist and he is a registrar of Tamil Nadu Medical Council. We welcome you, sir. Now we move on to Dr. Srinivasan Sampath.
Could you hear me?
Yes, sir. Yes, sir.
Good morning, everybody. And sorry about the throat. Thank you very much for your kind words and also offering me the opportunity to speak to you. And I'm very thankful to the ISA President, General Secretary, organizers, and all the members, students, and my beloved teachers. And the topic that I have been given is the field where I work most of the time, and also worked a lot there, anesthesia for laparoscopic surgery. I would call it anesthesia for minimal access surgery as well. Sometimes we work in the thoracic region as well, thoracic surgery, etc. Next slide, please. Next. Yes. As I said, it's a minimal access surgery. It's a newly expanding field. It's going at a very fast pace now. And we call it the day care procedure, where most of the surgeries are done. Of course, we do inpatients as well. And nowadays, we do even major complicated surgeries through minimal access, like anterior resections and pelvic surgeries and complicated bariatric procedures. And the demanding field now is the robotic surgery as well. It's a very special area, and we need lots of training and exposure to this field. But it is upcoming, picking up in some centers at a very fast rate. The minimal access surgery, it has got very unique features. The abdomen is a very interesting area. If you notice an extensive laparoscopic procedure, the amount of tissue damage done through the laparoscope is no different from an open procedure, open laparotomy. But these patients, they do very well postoperatively. But the moment you open the abdominal wall, then the postoperative stay in the hospital is extended like 10 days, 15 days, something like that. You can do some 6-7 ports in the abdominal wall and do a major surgery. Still, they do very well. There is enough evidence through many studies, and also the Royal College of Anesthetists, they conduct audit programs now and then. There was an audit called SNAP4, which showed a very good outcome with laparoscopic or minimal access surgery, even on patients with multiple comorbidities. And because it's a new field, for any surgeon, it takes some time for them to climb onto the learning curve. They might take even half a day to do one procedure, but the same surgeon, when he achieves the skills, he would be able to do 3-4 cases. Like in 4 hours time, he can do 3 laparoscopic cholecystectomies. My surgeon could finish a laparoscopic cholecystectomy in 15 minutes, skin to skin, very efficient. So when you have such surgeons, it's very, very productive for the hospital, very much like in terms of cost saving and the patient outcome, everything. And also the anesthesia has advanced. It's one of the fields in medicine which has seen the maximum developments. And we have very good agents for day care procedures, like we have remifentanil, desflurane, and muscle relaxants, rocuronium. It's a wonderful non-depolarizing thing. And opiates like fentanyl, sufentanil, etc. Not only that, the technology has gone so far, the monitoring facilities we have today in the field, it's amazing. And because of this, our understanding about the respiratory physiology, cardiovascular physiology, especially these two systems, so important for the minimal access surgery. Preoperative area, it's a new field developing very fast. Perioperative medicine is part of it. We are able to assess and pick up some of the very serious underlying comorbidities. Like if a patient has got undiagnosed carotid artery stenosis, nearly 90% may not have symptoms, we would be able to treat these patients beforehand and then go for the planned procedure. So we are able to do ASA 3 and 4 patients now through minimal access, which was not possible, or even if it was possible in the past, with more postoperative complications. and bad outcomes. Next, please. In minimal access surgery, quite frequently you see patients with very high BMI patients. And there are certain requirements. Of course, every patient who undergoes anesthesia, these requirements are there. But here, there are certain things I would like to emphasize. And all these patients must be in deep sleep. Having said that, why I'm saying is like, there are patients even now in modern terms have awareness under anesthesia. It's a nightmare. It should never happen now, but still it happens. One of the areas is patients coming for bariatric surgery. If you have the facility to monitor EEG monitoring, bispectral index, for example, which I use most of the time for these patients, at induction itself, you would know the patient's depth. So I keep it 60 and below most of the time. Very good analgesia. What I'm saying is just follow the triad of anesthesia. Excellent relaxation and full control of ventilation. Don't allow the patient breathing spontaneously and synchronized with your ventilation, etc. For these procedures, the full control in the hands of the anesthetist, which makes the surgeon make his work easier. Very good relaxation, pneumoperitoneum, and good ventilation. All these things very, very important. And in the minimal access surgery, for example, laparoscopy, cholecystectomy, or any other procedure, the one and the most important factor, the gas in the peritoneal cavity, which brings lots of changes in the respiratory physiology and cardiovascular physiology. And also extreme positioning. Sometimes a difficult laparoscopy hysterectomy on a patient, say around 160 kilos, extremely head down, it's a nightmare. You must see that to see the problems, what all things happening. And an anesthetized patient cannot look after herself. And there were many occasions patients had injuries because of bad positioning and brachial plexus injuries and sharp objects pressing against the patient's arms and things like all these things happened, which I've seen practically during my work in the theaters. So that's why I'm putting all these things here. Yeah, very good communication in the team is very, very, very important. Why I'm saying this, because the communication was not there, in UK, in one of the hospitals, the wrong kidney was taken out. So that's why World Health Organization has brought a new system called WHO checklist before you start the list. You discuss all your patients, your equipments, drugs, blood, any facilities that is available, also the skill level. If any team member has got any questions or safety of the patient is in trouble, you can raise your voice. You must be a good team player. As an anesthetist in the theater, you have overall a bird's eye view of the scene. You must interact with everybody, demonstrate a good leadership. Doesn't matter where you anesthetize a patient, in Rameshwaram or in New York, it doesn't matter, the principles are the same. Patient must be in sleep, analgesic, dignity maintained. There are so many things. These are all the principles, it never change. The facilities may be different. I may have desflurane for every patient. I can monitor the carotid flow or cerebral flow, something like that. It may not be available in a remote area, but the principles are the same. The principles could be achieved. Next one, please. In minimal access surgery, there are certain very hard fundamentals to understand. The one and the most important thing is the peritoneal pneumoperitoneum that we create to do the surgery, and its effects on two systems, the respiration and circulation. And you have to know what's happening in these two areas for a safe outcome of these patients, a successful surgery. Next, please. I'm very sure every one of you know these numbers. What I'm saying here, few things about the physics. The atmospheric pressure is one of the very important things which comes in our way. So the pressure in terms of millimeters of mercury at sea level, it is 760 millimeters of mercury. It is, for the trainee's sake, I'm just emphasizing this. It's a vertical column of air several kilometers above the sea level, how much pressure is exerting on the sea surface. 760 millimeters of mercury, or 1 bar, 101 kilopascals, 14.9 psi, pounds per square inch, or 29.9 inches of mercury. You can use any units of your choice. Millimeters of mercury is the common one. Bar is another one. Kilopascal is the most easiest one to handle. So one thing I would like to show you here, the oxygen is 20.9% oxygen, which amounts to 159 millimeters of mercury, and the nitrogen 78.6%, that is 597. Just keep these figures, and when we come to the pneumoperitoneum and other things, it will be useful. Next one, please. Next, please. Okay, as I said, the pneumoperitoneum is the most important thing here. And we have used different gases in the past. To start with, people used just atmospheric air to inflate the peritoneal cavity. People used nitrogen, many things, but now we have settled with the carbon dioxide because it's the safest gas that we can use. The volume of the gas in the peritoneal cavity is not the big problem, but it is the pressure. As long as you maintain the pressure within the peritoneal cavity, we are safe. Why the pressure is very important? In the beginning, when they create the pneumoperitoneum, they go for a high flow. You have to watch the patient in this situation. Sometimes, especially if the surgeon is new, suddenly they go for a very high flow and it builds up the pressure, and suddenly patient can go for a very severe hypotension, tachycardia, and even arrest. You have to be very careful. The needle could be in the wrong place. It may not be in the peritoneal cavity. So the initial phase is very, very important. And you would have seen most of the time, the working pressure in the peritoneal cavity is up to 20 millimeters of mercury. It may not go to 20, but sometimes even higher than that. But you keep an eye on these figures throughout. Without your knowledge, sometimes they change it. And why this pressure at 20 millimeters or 10 millimeters important is we need to know the figures in the inferior vena cava, hepatic veins, and atrium, things like that. We all know the venous blood flow is from the periphery to the right atrium. The muscle pump in the periphery is like your calf muscles, etc. When you are physically moving, etc. It helps to return the venous blood. So in the IVC, it could be around, say, 10 millimeters of mercury, and in the hepatic vein, it can go up to 12, and so on. The pressure, the flow moves to the center, right atrium. If you put more pressure in the peritoneal cavity, pressure on these vessels, it reduces the preload. The venous return is affected. So there is congestion of blood in the mesentery, in the pelvis, in the peripheries. That's what I'm. And also head off position, sometimes the bariatric surgeries, which is the opposite of gynae, they use a Trendelenburg step, pooling of blood in the peripheries, plus the pressure on these vessels cause more problems and reduces the venous return and thereby cardiac output. So what is the outcome finally is a drop in preload and ventilation perfusion mismatch, drop in saturation. If you catch these problems a bit early, it is easy to rectify it, and you can work with the surgeon very closely, like maintaining the pressure and adequate relaxation of the muscles. Next one, please. Thank you. So this slide, I would like to more for the trainees and people with some academic interest or max. So the carbon dioxide we use in the peritoneal cavity, I said it can go up to 20 millimeters or 25 millimeters or even more. And we have to realize it is not just 20 millimeters of mercury. We have to take the atmospheric pressure, which is 760 millimeters of mercury, plus this 20 millimeters of mercury. So 780 millimeters of mercury pressure purely exerted by the carbon dioxide in the peritoneal cavity. Yeah, leave it there. Let us come to the oxygen partial pressure in the alveoli. So we have a beautiful equation. One of the equations, there are many equations in anesthesia of very interest for the trainees and for everyone. One is the alveolar gas equation. So the partial pressure of alveolar gas equation is equal to the fractional concentration of oxygen within brackets atmospheric pressure minus water vapor pressure minus PaCO2 over RQ. That is the respiratory constant, that is the ventilation perfusion thing, ratio which you get it's 0.8. So sometimes we can, so you can work it out, say like if we put a value, say 40 or 50, something like that, you might get a value of 200 millimeters of mercury in the alveoli in anesthetized patients. Patients breathing room air, like you and me now, the alveolar partial pressure of oxygen is around 105 millimeters mercury. Whereas in the atmosphere, it's around 159, say 160 millimeters of mercury. So can you see the gradient, what it is like? I ask my trainees quite frequently, the blood on the floor in the operating theater, what is the saturation of it? Or if you do a blood gas on a blood sample from the floor and a sample from the patient, the blood on the floor has got a very high gradient. Yeah, 160 millimeters mercury, and there is nothing direct contact, so its PaO2 will be very high. PO2 will be very high. So the gas transfer in the peritoneal cavity is around 774, and the peritoneal membrane on all those tiny capillaries exposed to this gas, the carbon dioxide just literally flows into the blood. Yeah, so the CO2 climbs very high. Sometimes during laparoscopic nephrectomies, the CO2, end-tidal carbon dioxide, goes to 7, 8, 10, something like that. It is extremely difficult to ventilate or wash out this carbon dioxide. If you use nitrous oxide as a, like in your gas mixture, it's okay. But please remember in the alveolar gas equation, when you calculate, you have to add this nitrous oxide also to the water vapor to get the correct value. And if you want to raise the FiO2, if there is a saturation problem, in the presence of nitrous oxide, it's difficult. You have to reduce the concentration of the nitrous oxide. Next one, please. Coming to bariatric patients, like I have anesthetized, the maximum weight is 270 kilos, but not for bariatric surgery, for a tracheostomy. So patients like BMI, very high BMI, like 50 and things like that, they pose very difficult situations for you. These patients quite frequently come for weight reduction procedures, like gastric banding, etc. So where you cannot deny the surgery. But if similar patients comes for a total hip or knee replacements, we can postpone the surgery. We can tell them reduce the weight and come back, but not for bariatric procedures. And in these patients, one of the respiratory parameters to think about is the closing volume. So during normal breathing, some of those alveoli in the periphery, they do not remain open. So they go for closing at certain volumes. And as time moves on, this closing volume moves towards the functional residual capacity, which is the volume in the lung at the end of normal respiration, expiration. So as a result, it leads to ventilation perfusion mismatch and finally to hypoxia. And the supine position, a very high BMI patient, standing position is best for respiration, sitting, but the moment he lies down, the zonal change takes place and it leads on to ventilation perfusion mismatch. And one of the very interesting reflexes as anesthetist we should know is the hypoxic pulmonary vasoconstriction. What it is, those alveoli not adequately ventilated, and the perfusion to those alveoli, they are diverted because of vasoconstriction. This is a hypoxic pulmonary vasoconstriction. Less oxygen in the alveoli make those blood vessels supplying those alveoli vasoconstrict, divert the blood so that better oxygen can be achieved. The moment you anesthetize the patients, this reflex is abolished. You see a patient, say like 160 kilos, breathing 21% oxygen, saturating 96%, 97%. You put this patient to sleep, normal blood pressure, 100% oxygen, saturation drops to 70, 80, something like that. It is because of this reflex. All anesthetic agents abolish this reflex, but propofol probably the least, but it comes back reasonably early. And during bariatric surgery procedures, sometimes the airway pressures can reach even 50, the ventilators alarming all the time. And we have to be very careful. In a normal patient, you can reach these pressures, no problem, but there are certain situations. Suppose you had a very difficult airway, you can intubate, and we have used the bougie, and there is trauma in the trachea. High airway pressures can cause dissection along these lines, mucous membranes, and leads on to surgical emphysema, mediastinal planes, etc. So if you have such a patient, difficulty airway, bleeding in the trachea, etc., it's worth doing a quick fiber optic scope and see is there any mucosal tear. Otherwise, it's a nightmare. Obese patients, these complications extremely difficult. The air can dissect into the neck, mediastinum, and even into the peritoneal cavity, retroperitoneal spaces. Quite frequently, smaller tidal volumes, higher ventilator rate, high FiO2, maintaining the volume, everything normal. And the people have tried even like high frequency ventilations, tidal volume 5 mils, something like that, but the ventilator rate is around 2,500 or 3,000. So the tidal volume is so low and very high rate, you hardly see any movements there. It's very ideal for reconstructive surgeries, transplants and things like that. But in bariatric surgery, this is not tried widely, but in some places they do. The equipment is not a very complicated one. It's a very simple device. Next one, please. Coming to the monitoring, as I said before, the monitoring is a very new field. Actually, it is exploding like anything. And here in UK, we have standard monitoring. It doesn't matter what kind of anesthetics or what kind of procedures you do, the standard basic monitoring must be there. So to name, ECG, end-tidal carbon dioxide, oxygen analyzer, pulse oximetry, and blood pressure. If you don't have an oxygen analyzer, you cannot anesthetize the patient. You can refuse. Nobody can put pressure on you. In our setup, bariatric surgeries and long surgeries, not for cholecystectomies, I would prefer an outline because of positioning and a long duration and volume changes and CO2 problems. An outline is extremely good. You can do blood gases and you can see the electrolytes and hemoglobin, everything. BIS monitoring, that is the depth, anesthetic depth monitoring. And the spirometry loops, I really like this one. Before you start the case, once you intubated the patient, when the patient in normal supine position, save the initial loop, and that is your initial reference, and all the further ventilation, everything is superimposed on that. So you would know if there is a leak or if the patient is going for spasm or the airway pressure is high, everything is reflected on this beautiful background loop, and you can take steps how to rectify that. Coming to nerve stimulators, like it's one of the interesting areas for teaching the students. And in clinical setup, we have moved away from the hand twitch to the facial muscles and everywhere, but it is debated how truthfully it reflects the neuromuscular junction, but it is helpful. But in this setup, keeping the arm outside, it's very difficult. It's not easy. So I'm not a big fan of it, but if you want to use it, you can use. And organ perfusion, finally, whatever we do, the organ perfusion is the most important thing, all the vital organs. And we can monitor some organs, but not every organ is possible. The common thing is the urine output. If the kidneys are well perfused to maintain the output, you take it for granted most of the organs perfused. And the temperature is very important, especially the delta T. What is the difference between the core temperature and the peripheral temperature? If the gap widens, then your perfusion is not good, and you have to take care of it. Transesophageal Doppler monitoring, and I used to use this one, but there is a problem. The probe is very stiff and very difficult to position it, and also there is a danger you might perforate the esophagus. So, and also the artifacts are too many, it's difficult. And steep head down positions in these patients can go for facial edema. Even retinal detachments is a problem. And carbon dioxide washout is a very, very difficult one in high risk morbidly obese patients. It takes quite some time to be washed out. Make sure your blood gas, base excess, and the PaCO2, they are normal before you wake them up. Otherwise, they are confused, disoriented, vomiting. It's a problem. And next one, please. I think I've come to the end. I've covered most of the things. It's all based on day-to-day work in data. I've not brought any data from the literature. I thought I would do a session oriented to the theater environment and for the trainees. Thank you very much for the opportunities.
Thank you, Dr. Sampath Srinivasan. That is a very lucid presentation, crystal clear, especially focusing on postgraduates, along with giving them a lot of inputs to look into basics of your anesthetic care. I think over to Dr. Kameshwar Rao for the question answer session. You can type your questions on the chat box. I have some written down already. Some questions have come in. Dr. Kameshwar Rao, would you want to?
Dr. Srinivas, excellent talk. You covered almost all the basic aspects and also the important care that should be taken during these laparoscopic surgeries. And there are one or two questions in the chat box I have seen. During COVID time, one person has asked, what precautions you take for aerosol generation from ports can happen? What precautions you take during this COVID time?
Okay, just I would tell you, I myself handled these patients in the beginning without enough protection. So I got the COVID infection. And some of my surgical colleagues, they operated on trauma patients where they use the drill, etc. On COVID patients. They got the infection, and in fact, they were in intensive care for a few weeks. So it's like that. So what we do now, we have the PPE masks. We were tested for the face masks for any leaks. So we use those masks. And also we use the visor in front of your eyes and on top of the mask. And during intubation, we are extremely careful. We wear double gloves and the gown and everything. After intubation, we wait for about 10-15 minutes, especially COVID patients. Nobody is in the theater for about 15-20 minutes. And during extubation also, we follow the same rules. Extremely careful.
Thank you, sir. Any experience on gasless laparoscopy, sir? Because sometimes it is used as an alternative for the ischemic heart disease patients who cannot tolerate carbon dioxide pneumoperitoneum. You mentioned in the literature. Any experience on this gasless laparoscopy? You have got any experience?
Yes, sir. This gasless laparoscopy and then natural access laparoscopic surgeries, they're all the fields coming up. But the problem is the complications associated with these procedures, and then damage to the hollow organs, which is a problem. So for one problem, you want to avoid the gas, but you might end up in more problems later on. I doubt very much whether we would be going in those lines for major surgical procedures.
And regarding the pressure, suppose you have to go for a pressure of more than 15 millimeters of mercury, can we allow more than 15 millimeters of mercury? It has got its hemodynamic impacts of compression of IVC and all these things. And can we go beyond 15 millimeters of mercury?
Initially, they go up to even 20 when they do the pneumoperitoneum, but you have to watch your parameters, how each patient is. Some patients wouldn't stand even 15. Some patients could stand even 20 millimeters mercury. And each patient is different. So you keep your eye on these parameters and tell the surgeon early. The moment you see tachycardia or hypotension or change in saturation, things like that, you communicate with the surgeon. And before, if you do a difficult case in the beginning itself, I would discuss with the surgeon and team, this is the maximum pressure I would allow. And if there is any change, you have to reduce it. So a good communication from the start, it doesn't affect anybody. So
any special precautions you take in a cardiac patient undergoing for laparoscopic surgery?
Again, the pressures, actually, you don't cause too much compression of these veins. And even tachycardia is not good in these patients. And sometimes patients on beta blockers, they may not display, what is that, Mary's law, hypotension and tachycardia, these things. Yeah, you may not see. So you have to keep all your senses wide open.
What is your experience in pregnant patient coming for laparoscopy?
Pregnant patients in the later stages, it's very difficult. Probably in the first, second semesters, yes, I have done. One of the problems is the miscarriage in these patients. So you have to take a special consent and all that with the other colleague. And don't
Fetal monitoring also.
Yes, yes. So
And
the surgeon has to be experienced.
Dr. Sampath, I have a couple of questions to ask. So a very popular question on the chat box: regional anesthesia for laparoscopic surgery. I think a lot of centers, not a bigger centers, they don't involve themselves, but a lot of hospitals, per se, standalone hospitals, they do laparoscopy solely as under regional anesthesia. And what's your take on this? And what's your experience? I don't think UK they would allow normally also, but anyway, I'll leave it to your answer.
Thank you, sir. It's a very nice question. I don't want to upset the person who asked this question. Yes, definitely there is a role. I tell you how it is. Like, I do regional anesthesia for these patients. So sometimes the surgery for about 6-7 hours, laparoscopic surgery, I combine it with the general anesthesia. So what I do a spinal, not combined spinal epidurals. I do spinal, and we have diamorphine here. One of the few countries in the world who use diamorphine. So I put 300 micrograms of diamorphine in the subarachnoid space, and I use relatively a large volume of hyperbaric solution, say around 4 mils, something like that maximum, provided the patient is around 6 feet, something like that. And you get a level for this volume up to, say, T4, T3, but you don't wait for the patient to experience the difficulty in breathing. So you don't want to wait for that. The moment you see the patient can't lift the legs, the spinal is effective, and you combine it with the general anesthesia, you can use a small dose of remifentanil in the background and desflurane. If the procedure goes beyond 6-7 hours, the spinal might wear off, but still you have the diamorphine in the subarachnoid space that gives the analgesia. And your remifentanil, if the patient experiences pain, you would know tachycardia and other things, and then you can manage it with remifentanil. And at the end, patient wakes up beautifully, fully awake, communicating and things. Definitely, a regional has got a role, but spinal on its own, no, because the patient's position and comfort and other things. Thank you.
Yeah, that's. I think in India, I think we can even present innumerable number of references and papers. They do a lot of laparoscopy under spinal anesthesia. But as you said, the patient's acceptance for the technique, number one, and also intraoperative discomfort, both to the patient and the surgeon, has to be accounted for. And also there's the other problems associated with regional anesthesia and laparoscopy. So we'll leave it at that question. The next one, few more, couple of questions before we go to the next talk. Is a TIVA versus standalone TIVA versus vapor-based anesthesia? What's your choice?
Yeah, TIVA, you mean TCI, yeah? TIVA.
Yes.
Yes, yes. Yeah, I'm not against it. In fact, TIVA is a good technique. I do use TIVA as well. The monitoring is very important. Quite frequently, the awareness under anesthesia is associated with the TIVA. The pump tells you what is the site concentration, etc. The problem is it's a logical thing that's calculated in the pump based on the values you punched in. Whereas the end-tidal desflurane or sevoflurane, etc., is something is practically measured from the end-tidal gas that comes out of the patient. If there is a means, you can measure the plasma concentration of remifentanil and propofol, and that is a definitive parameter you can rely on. So your TCI or TIVA, propofol, will be going out somewhere from the patient, but the monitor tells you. So BIS monitoring, if you are using TIVA, it's very, very important tool. You can use TIVA, no problems.
Right. And a couple of more questions. Intraoperative hypertension during pneumoperitoneum. One of the questions was, can NTG completely prevent this problem? Or I would phrase it this way, what other drug choices you normally use to counter the hypertensive response to pneumoperitoneum induced by CO2?
Okay, there are two issues here. Initially, the system responds due to a reduced preload, tachycardia and hypertension, vasoconstriction, that you must identify and exclude from a patient poorly controlled hypertension and responding with high blood pressure. So nowadays, like sartans and remifentanil and other things, we don't give on the day of the procedure. Most of these patients' preoperative blood pressure itself, say 160, 100, 105, like that. So we don't cancel these patients. You do take them off. GTN is a very good drug. I use it in patients with unstable angina, coronary problems. You run it in the background. And one of the problems with this drug is the tachycardia. So you like to protect the myocardium, reduce the oxygen demand by reducing the rate, improving the coronary circulation. But on the other hand, it might take more oxygen by doing a higher rate. So under those circumstances, you have to go for a beta blocker. So the second question, like poorly controlled hypertensive patients going for hypertension on the table, one is a beta blocker you can use. Labetalol is one of the things which is immediately available, but patients with asthma and other things, sometimes it can cause problems. The other option, if you have a TIVA, remifentanil and propofol, very easy to control the blood pressure as well. With the GTN, yes, it's a very good drug. Quite frequently we use GTN, but you have to be careful like the tachycardia.
The common drugs which we use, or at least we are quite happy using it, is dexmedetomidine. That's quite popular with probably the Indian doctors, controlling the blood pressure response during a pneumoperitoneum. It's quite excellent response control of the hypertension. I think you should try that, and it's quite a good drug to add up to your beta blocker or other drugs to control the blood pressure.
Is it dexmedetomidine?
Yes, yes.
Alpha-2 agonist, isn't it? It's a pure.
Yes.
Yes. But that drug is not very popular in the West, but
That's
the
what I
West
said,
they
in the
use a
Indian
lot.
population.
Yeah.
Go ahead. Yeah, that's Sampath.
Okay. Yeah, this dexmedetomidine, it's a very good drug. It's alpha-2 agonist compared to clonidine, which is alpha-1 and alpha-2. So in future, especially acute and chronic pain therapy, this drug might play a very important role. We don't have, I have never used that drug here, but some of my friends who work in the veterinary field, they do talk about a lot.
It's one of the very popular drugs here. I think if there are no other questions, I think one last question was control of renal perfusion during high pneumoperitoneum in a CR of end-stage renal failure patients coming in for laparoscopy was another question. And any tricks and tips on that?
Yes. In the preoperative assessment, if you notice anybody with a reduced GFR or patients who are waiting for AV fistulas and or even renal transplant, sometimes you do see these patients. The important thing is maintain your perfusion. In anesthetics, we don't have any rights to stop oxygenating the cells. The delivery of oxygen to the cells at the mitochondrial level is the most important thing. You may maintain that all the time. The only way to maintain is maintaining the DO2, delivery of oxygen. In other terms, you need to maintain normal blood pressure and saturation. So how do we monitor it intraoperatively? The urine output. You have to maintain the minimum urine output 0.5 ml to 1 ml per kilo per minute, something like that, every hour continuously. If you reduce the renal perfusion even for 10, 15, 20 minutes to a very lower level, the nephrons, the very sensitive, high oxygen demand cells would be damaged. And this effect you can see in the postoperative period in terms of raised creatinine and reduced urine output. So maintaining the normal perfusion is very, very important in these patients. And postoperatively, such patients should be monitored in a high dependency unit, level 2 beds, basically. Thank you.
Can I ask one question?
Okay, sir.
Yeah, there is one question in the YouTube. In COVID recovered patients, what is the problem of laparoscopic surgery in the post-op period? In COVID recovered patients, if they come for laparoscopic surgeries, what are the problems you expect?
Okay, thank you, sir. The COVID has changed our understanding of the human physiology completely. It has changed. I'll tell you one incident. I did a fractured neck of femur patient and the saturation was 75. I didn't believe that, but when I checked it myself, it was 75. And with the pre-oxygenation, it went up to about 96. And within about 10-15 minutes, it's back to the same, like 71, 75, something like that. And after the procedure, we extubated, patient came back to the same value. And where is our understanding about the physiology now? If somebody is at that level, they are a bit confused, disoriented like that, but this patient was not. COVID has taught lots of things in respiratory physiology. One of the important things is the microcirculation, and in the lungs, the fibrosis. So they produce kind of restrictive lung disease. And my colleague, Dr. Angu Kumar, would highlight more on that in the next lecture. So you have to be careful or look, if possible, do a lung function test before. And what I mentioned in the monitoring, the spirometry loops. The spirometry loops, you can infer like different lung conditions like bronchospasm, restrictive lung disease, etc. So in the beginning itself, you would know what is the underlying thing. So you have to be careful with the airway pressures, and you have to use maybe smaller tidal volume pressure controlled ventilation. So you don't pressure controlled and volume guaranteed or pressure controlled. So whichever things which you fancy, but look at the safety of the patient. You don't want to cause a pneumothorax in these patients or pneumomediastinum, leading on to more complications.
And adequate care in the post-operative period also, because to see the oxygen levels in the post-operative period also.
Yeah, absolutely,
As you
sir.
mentioned.
Yes.
So thank you, Dr. Sampath. If there are no further questions, then we can wind up this session. And with plenty of thanks from all of us for sparing your vital time on a Sunday morning. And it has been a very interactive discussion and very nice presentation. Thank you, Dr. Sampath Kumar Srinivasan, for your presence and your total involvement in taking enough time to answer all the questions, how much ever sort of simple or sometimes complex questionnaire. I think it was very nicely dealt by you. Thank you so much for your presence. And with that, we conclude this laparoscopic session. We'll proceed to the next lecture. May I invite Dr. Angu Kumar Tangamuthu. He's also working in the same institute. He's working as a consultant anesthesiologist and a college tutor. If any of these postgraduates or anybody wants to get into any training scheme in UK, he's the man to contact. College tutor means they are directly in touch with the Royal College. So they are the people who would help you in training. So that's very important. And he monitors the training of the postgraduates or the trainees in his training rotation institute. And then they assess them, and then they'll recommend to the Royal College for their progress. And his special interest in obstetric anesthesia and plenty of interest in teaching and training. And he's a consultant in Basildon and Chirac University Hospital NHS Trust. Thank you so much, Dr. Angu Kumar, for joining us with a nice, very interesting topic, the oxygen therapy or oxygen handling oxygen requirements in COVID patients. Thank you so much for your presence. You may kindly proceed with your talk, sir.
Can you hear me?
Sir.
Yes.
Yeah.
Yes, sir. Yes, sir.
Okay. Thank you so much. I'm just starting my.
Please a bit louder, sir. Please a bit louder.
You can increase the volume on the microphone.
Hear me? Hello?
Yeah,
Better.
Okay, perfect. I'm starting the screen sharing. Are you able to see? Hello?
Yes, we are able to see the slides.
Okay, thank you so much. I'm Dr. Angu. I would like to talk
But
about
audio is not heard.
oxygen.
Audio is not clear, sir.
Not
Can you hear
heard
me
at all.
now?
We want a
Hello?
little louder, little louder.
What I'll do, I will take my my microphone out.
That is
Can you
better.
hear me?
Now it is all
Hello?
right. Sir, it is all right.
Yeah. I would like to talk about oxygen therapy for COVID patients. I got few slides, as well as I'm going to talk about one important article, and I would like to share my that articles with our anesthetic, but this because that is very important for their well-being. Okay, I'm starting with that now. Um, in this talk, I would like to highlight something. I'm starting with the pathophysiology, classification of COVID, and I would like to say, the silent hypoxia and the key recommendation in the oxygen treatment for COVID, as well as the concepts of ventilation, and I would like to talk few things about the ECMO. The whole world is now, worrying about COVID. The 15% of the whole COVID infected patients are coming to us in any other form, like they may have either moderate or severe disease. They're requiring hospitalization. And 5% of the infected patients, they are coming to the intensive care, and they are requiring any intubation or ventilation, or they may have severe pneumonia, they may develop ARDS kind of a picture, or they may have a septic shock or multi-organ failure. This is the worrisome. The whole world is worrying for this 5%, because the main reason is the 30% mortality rate of the patient who's been admitted in the intensive care. That's what our main area of concern, and as well as our preventive strategies to avoid this ITU admission. Just don't worry about the other description. I want to show this picture with the healthy and the infected and moderate to severely infected alveoli structure. The main thing is here, the structural integrity of the alveolar and the microvascular, the pulmonary vascular, and the slowly is getting infected, and the inflammatory markers are sweeping in the fluid, and then it reaching the alveolar, and it is getting filled with a fluid with more of a transidate type. But the problem is when there's a fluid or getting more protein rich, more of an exudate with loss of surfactant. The main problem is when comparing the gas transfer, the oxygen and carbon dioxide transfer here and the healthy, that's where the problem is. So this is the basic pathophysiological, structural based alveolar and pulmonary vasculature. Basically, this is a RNA virus, but the main pathophysiology, it starts with endothelium, endotheliopathy, and it causes the high viscosity of blood and increases the coagulation. With that, every organ are affected in different way. In pulmonary, the exudative alveolar damage with microthrombi, this is the most problematic pathophysiology which causes death. So when I'm comparing here, it's like this picture shows that the normal epithelial and endothelium on the left side and the diseased structure on the right side. It starts with the endothelial damage and increases the vascular leak, and that causes the pulmonary edema and with neutrophil and inflammatory cells that causes the cytokine storm. With the SARS virus is infecting the type 2 alveoli with the infected alveolar epithelium with the cytokine storm. This is the major problem. I will come back to that, the importance of the cytokine in the later stage. So the vascular structure is getting damaged, the platelets are activated and causes vascular leakage, and that causes the pulmonary edema. Silent hypoxia. This is an important consequences that most of the anesthetists are coming across. Dr. Leviton, that he's worked in the intensive care and emergency medicine for 30 years, he said, majority of the COVID patients I'm meeting is with low saturation in the triage. It looked like that saturations are so low, even I'm worrying that it's incompatible with life, but they were using their cell phone. That kind of a paradox. So you will be puzzled. And many times when I'm going to the A&E resuscitation, and after getting the information and the blood gas report, when I'm telling the patient, dear, I'm going to intubate you, they'll be puzzled. Why? Because they don't know the seriousness because of the silent hypoxia. They're quite calm. Why it's happening? They have done in the experiments in the hypobaric chambers. The hypocapnic hypoxia, it is in paradoxical, it gives a calm feeling. Patients, they're quite right. They're fine. They may be using the cell phone or they may be talking to someone else, but they're unconsciously, they are hyperventilating without obvious dyspneic picture. Yeah, that's the thing. There's a little bit distress, but otherwise they're fine and they'll be doing, they're cooperative and they're hemodynamically stable. The problem is they are stretching their reserve and there is a sudden and respiratory deterioration is going to happen. So this is an important thing that we have to be careful in the COVID. Because this slide shows the relationship between the PaCO2 and saturation, because there is a hyperventilation trying to compensate for low saturation. Also, there is a leftward shift in the oxygen dissociation curve. There is increasing affinity for the oxygen. And most of the time, they're not that much distressed. So there is a recent articles, they highlighted how COVID and the high altitude pulmonary edema, they are interrelated. The carotid body, which senses the hypoxia and gives the signal to the brains, the brainstem, and it gives it. I'm talking about the normal patients. That gives the central command. It increases the compensatory increase in respiratory frequency or tidal volume. That one is attended in COVID. Same thing. It's the similar picture happening in the high altitude patient. If we've been exposed to the high altitude suddenly, the saturation will be very low, yeah, dangerously low, but they're not that much distressed. So that is a basic pathophysiology. COVID classification, it is for the clinical picture, it is classified as mild, moderate, severe, and critical. Mild is for those patients with infected, and no signs of pneumonia, and radiologically they are fine. Moderate, they have a fever and the respiratory symptoms with radiological findings of pneumonia. The severity is that when there is a respiratory rate, it increases more than 30, and saturation is less than 93%, and the PaO to FiO2 ratio is less than 300 with the infiltrates, then this is severe. And the critical is, along with that, they may have a shock or failure, and they may end up in septic shock or multi-organ failure. This is the severity of the COVID. I'm not talking about the extreme other the lateral aspect of COVID. I'm just giving a key principles of COVID management. It starts with oxygen, and we start with IV fluid. Titrate the fluid because we have to be careful with the IV fluid. In the severe COVID, without shock, if the patient is not showing any shock, we are trying to keep the patients negative 0.5 to 1 liter negative per day that we aim if the patient is not in shock, obviously if they are hemodynamically stable. And the other important key aspect is the venous thromboembolism prophylaxis. Yeah. Every hospital, they have a different protocols, low molecular weight, heparin. And the next comes the invasive and the non-invasive ventilation. And the last resort for the ventilation is the extracorporeal membrane oxygenation, which is called ECMO. And it's also, along with the sepsis and the septic shock management also going along with this therapy. There are a lot of recent advances about the treatment. Usually they will have empirical antibiotics to prevent the bacterial infection, and systemic corticosteroids. They are advising for about 7 to 10 days in the adults with severe COVID disease, and other drugs like antiviral drugs. There's lots of drugs even under the guidelines. And the most important is the rehabilitations after once they have completed the treatment, and there is a definite plan for their chest physiotherapy and the rehabilitation plan following the discharge. In the typical, the setup, the teaching hospital setup or in the specialized center, they have 3 areas, the normal ward and the treatment in the ward, and then they may end up in the high dependency or intensive care, and specialized center, they're doing the ECMO. So the 3 category of the levels of treatment for COVID, they start with the nasal cannula, or they may end up in the next step is the non-rebreathing mask. The non-breathing, it gives about from 60 to 95% FiO2. Then the next step is either you intubate or non-invasive ventilation. The non-invasive ventilation setup, it is a lot of debate about the setup for the non-invasive ventilation, because those who have organized the ventilatory setup with a high level of ventilatory care, then there is a possibility that you can have the patients with the non-invasive ventilation. Because the reason behind is there is a definite strategy to deal the patients when they are having a sudden deterioration. So it's like a controlled test. There is a possibility with the non-invasive ventilation. I will talk about the inclusion and exclusion criteria a bit later. And then they may end up in the ventilatory support in the intensive care. If they are not getting better, then they may end up in the extracorporeal membrane oxygenation or ECMO. Also here they mention about, I mentioned 30% survival rate for the intensive care or the HDU or ITU setup, and it's about 20% survival rate for the ECMO patient. What is the oxygen aim for the oxygen treatment? If the patient's coming with the respiratory distress or hypoxemia, we are aiming for saturation 94%. Or if the patient's with the respiratory failure, we are aiming for about saturation of 96%. If they are stable and it's a non-pregnant adults, then they will aim for saturation of 90%. And for the pregnant patients, they are aiming for about 92 to 95%. High flow nasal oxygen. The different countries, they have accepted is a form of non-invasive ventilation. But the main problem is it is the healthcare workers, they need to have the PPE, and they have a special room and arrangements if they are having the non-invasive ventilation, mainly because of the contamination. Because the high flow nasal oxygen, even the rates, it starts from few liters, like 4 liters, it can go up to 60 liters. So there is a high chance of aerosol generating possibilities. So it needs the PPE protection and isolation. So there's a thing, but along with the other non-invasive ventilation, some other countries have been using this high flow nasal oxygen for COVID patient. But I haven't used in the UK. As I said, the non-invasive ventilation with the CPAP, they are using the CPAP, and it can be used as a time buying measure. It can, when you have all the setup and the close monitoring is possible, you can use this non-invasive ventilation with the CPAP with a different setting. It starts from a number 10 centimeter of water. It can go up to 15 centimeter of water. But again, there is an increased risk of aerosolization with a poor fitting mask is possible. And so there will be a definite care for the escalation should be there for the non-invasive ventilation. This is a guideline for the critical patients. If this basic principle is help to triage the patient if you have a non-invasive setup and invasive ventilation in the ITU care. If the PaO2 and FiO2 ratio is less than 150 millimeter of mercury, nothing, straight away intubation, and you start the lung protective ventilation. If it is more than 150 and if the ROX scoring, that is, it depends upon the FiO2, respiratory rate, and saturation. If that is permeable, then they can maintain the patients with the non-invasive ventilation. Even with the non-invasive ventilation, careful monitoring if they are deteriorating in terms of increased tidal volume or the ROX scoring, as I said, that depends upon the rate and saturation. If that is getting worsen, just to keep a close monitoring, and or if there is any sudden deterioration even within that parameters, then they are advising for an early tracheal intubation and start the lung protective ventilation. So this chart will give some kind of an idea about the triage and then ventilatory decision making. It may be, it is. In the UK, we have a merit team, which we normally go with the anesthetist and ODPs, and then in the different areas of the hospitals, we use the blood gas and other strategies. But this pathway will also be helpful to make some decision on the ventilation. What are the ventilatory strategies? The main thing is for the COVID patients, we use the lung protective ventilation. That is, we use the low tidal volume and inspiratory pressure carefully titrated with the delta P. What is that? The delta P is peak inspiratory pressure minus P. That is one of the driving pressure. We keep it around, the less than 30, and a little bit higher PEEP, but carefully titrated against the ventilatory changes and the changes happening in the peak inspiratory pressure and all. The severe COVID patient, we use the prone ventilation. Yeah, the prone ventilation, we did it at about 12 to 14 hours a day, can be needed. And all the strategies are the individualized ventilation strategies, rather than if it is a protocol. Yes, we use it as a guidance, but we make the more titrated for each individuals. ECMO. There are 5 centers in the ECMO regional centers in the UK, and they are all driven by the referral criteria. And it's quite highly resourceful. So, the cost of maintaining is quite high. So they are very strict in the referring criteria for the ECMO. I'm just giving the inclusion criteria. Main thing for the for ECMO is mainly the lung is damaged, but not the, basically I'm talking about not the general condition, in terms of if they have failed prone ventilation, or if the lung injury score, that is the Murray score, that if that is more than 3, that means the Murray score, it depends upon the peak and the PaO to FiO2 ratio. With that, if that score is high, then they will accept the patient, as well as the clinical frailty score. That is that depends upon how they are independently living, other organs involvement, that depends. So if that general other organs are better, are doing fine, and there is a lung is more of the problem, then they will be going towards the ECMO if the other parameters or other ventilator strategies are not successful. And if there is a refractory, the exclusion criteria for not accepting the ECMO, or if there is a multi-organ failure, or if there is any neurological problems, then they are not favoring for the ECMO. Quick reminders. I like to give, it starts from the endotheliopathy, and the main problem is if there is a proteinaceous alveolar exudates that causes the gas exchange problems, that causes the hypoxic damage, and ultimately the multi-organ failure. Also, please beware of silent hypoxia, and after that there is a sudden deterioration is possible. And we have target oxygen saturation measurement, which we need for individualized, and we aim for that oxygen treatment. With that, I'm completing the slides, but the most important thing, I would like to share one important article regarding the COVID. Can you see?
Yes, now.
Yes. This is an article published in the in April 2020. Yeah, they said about the evidence of vitamin D on the infections, but they highlighted more for the healthcare workers, particularly those who are dealing with the COVID patients. With that, actually, I got the permission, and we are almost about to start the project for the healthcare workers and the vitamin D level. What they are saying that if the healthcare workers vitamin D level, if it is about 40 to 60 nanogram per ml, yeah, they're saying that everybody knows that vitamin D helpful, but they are giving a specific number for that. So 40 to 60 nanogram per ml, if that is there, there's statistically significant less incident of the severe and the critical COVID infection. That means that is what we are worrying about, the severe and critical COVID infection, which they are ending up in the multi-organ failure or ventilation strategies, or that one is statistically less. So they are advising to take this as an important discussion in each of the unit or the hospital you are working to find it. Because here there are a little bit controversy in the dose. Yeah, some of the even UK, they said that the recommended doses is 400 international units per day and maximum of 4,000 international unit. But here, they're saying that high dose for a few weeks, and then to follow it with the, they're saying 5,000 units per day. That keeps that top up your blood level quickly to that safe level, which is recommended 40 to 60 nanogram per ml. If that is the case, you're statistically less chance of getting severe and critical COVID infection, because that goes to the pathway of the in the cytokine storm prevention. It is there, but the coherence, the bout and burst with the cytokines, and that lead on to the proteinaceous exudate, that pathway is it is statistically less, and that is what we are more we are interested. With that, I'm stopping my my schedule, and thank you so much for your patience.
Thank you, Dr. Anga Kumar. That was excellent presentation under the circumstances, touching on very important aspects and very practical guidelines and what's prevalent, because your people are much more earlier to start treating these COVID patients. I think in India we are catching up, and now we are almost reaching the peak level. So we are slowly catching up with you on the expertise. But having said that, your strategies for oxygen therapy is excellent, very well presented, and there are quite a few questions. Dr. Kameshwar Rao sir, you want to supplement and ask them?
Sir, very nice presentation. And regarding this COVID time, this oxygen therapy requires a good knowledge for by everyone, because now most of the centers are running deficiency of oxygen. Particularly in Andhra Pradesh state, we are facing this problem. Unnecessarily, where it is not indicated, some people are pushing high flows of oxygen and afraid of the pulse oximeter readings. And you have clarified clearly what should be the normal level should be maintained. And particularly in COPD patients, we will maintain at 88 to 92, that saturation is adequate. And all these things to be kept in mind while administering oxygen to these patients. And start with always low flow, some nasal cannula or Hudson mask. If it is prolonged, it is very difficult to tolerate because the dry gases. Then you can go for non-breathing mask. And HFNO is another thing, is very frequently used in our country, and that is avoiding unnecessary mechanical ventilations. And those who are going on mechanical ventilations, the survival rates are very less compared to HFNO. That's why the most preferred way of administering oxygen in our country. And I want to have your this thing share with your experience on HFNO, sir. That is asked by some of the delegates also.
The HNO4, yes, the particularly the Australian and other countries, they are quite carefully using this one. But the problem is, even the nasal high flow, it gives some kind of a positive pressure. Yeah, that uses it buys the time between in the clinical deterioration for the mechanical ventilation. But the problem here, particularly in the developing areas, there is it needs patient isolation, and then the healthcare workers, they have to wear the PPE, and they have to be they have to protect themselves. And but they may end up in intubation if their scoring, as I said, the saturation, respiratory rate, and the tidal volume, that needs to be monitored quite carefully. So I have used the other non-invasive ventilation with the CPAP, and we normally go and see the patients and make a decision and see how they are improving with the blood gas monitoring and all these things. If there is any deterioration, even if they are clinically they are doing well, we have a low threshold to intubate and continue our lung protective ventilation.
Another question, Dr. Raghu Kumar, is from one of the viewers. Proning for morbidly obese. Do you normally do that? Or what's your guideline for what's the weight limit? Or in other words, to up to what weight of the patient do you have any criteria to prone them? Or you prone everyone?
Not actually. The severe morbid obese maybe, I don't know the exact date, but we have prone the patient with the BMI of 35 to 40. We have prone, but the problem is we have to have the pressure areas needs to be monitored, and it needs the face and other abdominal area needs to be protected appropriately for the proning. For the pregnant patient, proning, obviously we can't do. We give the lateral decubitus position, and we tried with the some of the patients, they won't tolerate. We have to deprone immediately. That could be the worsening conditions, or the pressure area, abdominal pressure is compressing the diaphragm, and they may deteriorate suddenly. So we have to deprone quickly. So with the severe morbid obese, obviously that we can't do it.
Right.
As you said, you can turn the patient, sir. Lateral decubitus position can be tried for those people for some time.
Sometimes it can be tried for the. That's true.
Next one would be on air trapping. Air trapping quite commonly seen in COVID patients, and the implication of that causing a poor cardiac function post-COVID recovery state. And when they come for an elective surgery, what precautions you should take? Cardiac function, yeah.
There is a sudden increasing the airway pressure as alerted us a couple of times, and then we disconnect the circuit, and we make sure that it, and then reconnect and then restart it. Particularly for the cardiac patients, that causes the sudden increasing the airway pressure and decrease the cardiac output, and all these parameters we closely identify, and then we disconnect and then reconnect the circuit, and we carefully titrate the PEEP accordingly. And for that, the delta P, as I said, the ventilatory strategies with the driving pressure and the PEEP pressure and tidal volume, we keep a close eye on that. And if there is any problem, either we see is there any lung pathology or lung strategies we need to address, or is the PEEP which we need to disconnect and then reconnect.
Right. And
sir, another thing is like any ARDS, we should use low FiO2s. That is just adequate to maintain good saturation instead of going for high FiO2s. Of course, in the initial phase, we start with high FiO2, but as early as possible, we have to come back to the lowest possible FiO2 that can maintain adequate oxygenation. That is more important. Otherwise, there will be more possibility of a lung injury with oxygen. That's my.
Ranga Kumar, another question is on reliability of PO2, PCO2, and what levels would you sort of take it for guiding your intubation? PO2 and PCO2 values. How does that guide you to choose your intubation strategy?
That is the PO2 FiO2 ratio. With that, if it is around 150 millimeter of mercury, then if it is less than that, then it is that means that you are giving a more oxygen and you're not able to generate the PaO2 accordingly. So then it is a definite indication that it needs to go for invasive ventilation and and continue the strategies. If it is more than that, more than 150, and if they are conscious and if their respiratory rate and the saturation are maintaining, as I said, it's a ROC scoring, if then we can maintain in the non-invasive ventilation, which we can try with the CPAP. But the thing is we need to have a close monitoring, and then if there is any sudden deterioration, we may tube the patient quickly.
As far as vitamin D is concerned, in India, it's available as 60,000 units weekly once dose. Is that okay? Because everyone takes it. Even I have been taking it for quite a few weeks now. They recommend 60K tablet capsules for about 6 weeks time, once in a week.
Yes, because that is a bit high dose.
Yeah.
But the safety of the high dose has been tested in a couple of randomized controlled trials. One of the things I remember is those who have breast cancer surgeries, those who had a severe the metastasis and all these things, they're trying to improve their calcium and their well-being. They have tried the high dose of 60,000, and it was the not much clinical problem have been. The only thing is the hypoparathyroidism, the calcium possibility. But what they're trying to say, 10,000 units per day for 4 weeks, 4 to 5 weeks, plus and followed by 5,000 units per day, that it reasonably restores quickly to your safe level of safe blood level, which is they're saying that 40 to 60 nanograms per mL. So that is your aim. You as long as if it is a safe, whatever you can choose either this 60,000 weekly or 10,000 per day for a few weeks. So your aim is to reach that level to avoid the severity of the COVID infection.
Okay. There is one question on the chat box. Kindly explain the role of oxygen hood, NIV, and related ventilator settings. How is it different from mask NIV?
I have seen, the hood NIV, but I haven't, used it specifically. In our hospitals, we haven't used that the hood NIV. The mask it gives, and the hood they have after testing, they will use the hood with for the NIV ventilation. The mask, it is self-explanatory. It is basically it's fitting like that. But there is the hood. I heard that it's better compliance for the ventilation than compared to the mask ventilation, and the aerosol generation, there is a slightly higher with the mask than the hood. That's what my understanding, but I haven't used personally.
I think with that, no further questions. So over to Dr. Kameshwar Rao and Academic Chairman Dr. Edward. Do you have anything to question? Any questions from your side and wind up?
Only one question. So, what is the mortality rate in CKD patients with COVID in our hospitals? We have high mortality with the CKD patients on dialysis.
That is true, because most of the patient, they are saying that's about 30% mortality for ITU patients in general. I'm talking about, but I've seen it is more than 50 to 60% mortality, particularly when there is having additional one organ. The most important thing is with the kidney disease, and there is a high chance of the people are ending up with the acute kidney injury because of the microvascular angiopathy. And that is another important strategy that we have to maintain both the MAP and perfusion pressure along with your lung protection, because one time our hospital mortality was about 50 to 60% along with the COVID and organs failure, particularly with renal failure.
Thank you, sir. We are on par with your mortality rate. Thank you. Sudarshan sir, okay. Shall we close with the...
Yeah, one question from Shankar, the last one probably. My friend Shankar from Shankar Subramaniam from Salem. His question is, as SpO2 is not reliable, can we use alveolar arterial gradient as a better marker for predictor of prognosis of the pulmonary function or oxygenation?
That's true. Alveolar arterial, the gradients,
Gradients,
and
yeah.
the ratios are preferred way of making. It helps to make the decision, but for the other strategies, like if they are getting better, then you have to maintain rely on the saturation. The alveolar arterial gradient and your FiO2 PaO2 ratio, that it is more reliable method of making the decision, particularly when there is about to make where you can triage the patient, whether in the ward or in the intensive care. That is a quite useful guidance.
Correct.
Okay, sir. If there are no further questions.
There's one question in the YouTube.
Yeah.
How to determine ROX criteria?
The
ROX criteria.
ROX index.
ROX index. This is about the respiratory rate, FiO2, and the saturation. With that, these are all the key things that they are the components of the ROX scoring. Yeah. With that, if your FiO2 is going up, if the respiratory rate is going up and the saturation is going down, then your scoring will get worse. Yeah. So then that will be helpful for making a decision for intubation and ventilation. So these are all the components of the ROX scoring.
Anything else, Kripa? I think we'll wind off. Thank you.
Yeah, we'll wind
Yes,
up.
both of you, and Dr. Kameshwar Rao sir for joining in as a special invitation chairperson
Thank you, sir.
entire session. And thank you very much.
Second, Dr.
Yeah.
Sudarshan.
Yeah.
I've
Thank
seen
you,
my. Can you hear me?
Yeah.
sir.
I've seen I've seen Dr. Subaya, who was my teacher from Madurai Medical College. I want to say my greetings to him.
Yeah. He's there.
I'm his student, and when I'm browsing through that, I saw him, and I want to say my heartiest greetings to him. Thanks a lot.
Thank you. So if we'll proceed to the next session. Thank you, the speakers, both of you, Dr. Sampath Srinivasan and Angu Kumar, and Chairperson Dr. Kameshwar Rao sir. Now we'll go on to the brief sessions of branch report. Over to Dr. Kripa to announce all that. Thank you. We'll go to Dr. Kripa, Secretary. Thank you.
Yeah. Thank you. It was an excellent session. A lot of interactions. So we thank both speakers. Now I recognize the presence of Dr. Yaganatha Pillai from Madurai. He is a retired professor from Madurai Medical College and an excellent teacher. Thank you, sir. Now we will move on to branch report by ISA Theni City Branch Secretary Dr. Balasubramanian.
I'd like to thank
Please,
Dr.
sir.
Mahesh. Thanks.
Yes, sir. Good afternoon to all. So the branch report of ISA Theni City Branch. So since the onset of COVID-19 pandemic, we regret that we were not in position to conduct a monthly meeting of ISA Theni. So before that, in Feb 2020, we had interesting case scenario discussion among all anesthesiologists of Theni. It went on with smooth discussion and knowledge sharing between the senior and junior colleagues. After that, we conducted online Zoom lectures every month on the topic of HFNO, oxygen therapy, non-invasive ventilation, and other latest treatment modalities of COVID management. Our president, Dr. Kannan Bhojaraj, clarified all the doubts raised by the fellow anesthesiologists all over the world. I am proud to say that we are also in a position to run a COVID ICU in our setup and to help recover the maximum number of admitted COVID patients with HFNO and all gadgets. We are the frontline COVID warriors, and we, the anesthesiologists, are very proud of our role in this regard. There is no doubt that in this initiative of conducting weekly online Zoom meetings by ISA Tamil Nadu will go on a long way to better our efficient function and give relief to maximum affected patients in this pandemic time. Thanks to Tamil Nadu ISA, the President Dr. Sudarshan, Dr. Secretary Dr. Kribavaran, and academics Dr. Edward Johnson on this initiative, who took the Tamil Nadu ISA to the next level. I especially thank Dr. Srinivasan Sambath Kumar and Dr. Angu Kumar Thangamuthu, who delivered a wonderful lecture. Everyone enjoyed this and who accepted readily on behalf of the TENI ISA. Really thanks, sir. Thank you.
Thank you, Dr. Balasubramaniam. Now I want to make one announcement. For credit hour certificate, those who attended the program today, please contact your local branch secretary. They will guide you how to get the credit hour certificate. If you are not attached to any of the branch, please contact Tamil Nadu ISA directly, our state office. We will guide you to get you the credit hour certificate. With that, we come to the end of the session. We thank all the delegates who attended the meeting today, and we thank both the speakers from UK, Dr. Srinivasan Sambath Kumar and Dr. Anku Kumar, and our moderator, Dr. Kameshwar Rao sir from Andhra, and our academic committee chairman, Dr. Edward Johnson, for conducting this program so well. Thank you very much, sir. And our next meeting on next Sunday will be conducted by ISA Pudukkottai branch. So we will see you on next Sunday at 11 o'clock. Thank you very much. Thank you, sir.